Hello, we are a group of Lebanese University medical interns doing our internship at the Zahra Hospital. Today we will present an essential clinical skill, measuring the jugular venous pressure, also known as the JVP. We will show you real patient cases, the anatomy you need to know, and how to measure the jugular venous pressure properly. Also, we will present to you what high jugular venous pressure means in different conditions. So stick around to the end for a quick quiz, and let's get started. Now we will start with the anatomy of the internal jugular vein. Running along the sternocleidomastoid muscle, the internal jugular vein provides deoxygenated blood directly to the right atria. Therefore, the pulsations at this level will present the hemodynamics of blood at the level of the right atrium. The jugular venous pressure can indirectly determine the central venous pressure. Therefore, using the method that will be explained by my colleagues, which relies on the pulsation of the internal jugular vein, we can interpret the volume status of the patient. And when we estimate the volume status of the patient, it provides important information regarding disease processes and medication management.
Mr. Adam, good morning. How are you doing?
Fine.
May you give us your permission for the neck examination?
Yes.
This exam will be without any harm.
Yes.
Okay. Thank you.
The jugular venous pressure is to use the internal jugular vein, but the external jugular vein is also useful when it's hard to visualize the IJV. The next step is to examine the neck veins, and in this patient we'll examine the external jugular vein. The external jugular vein runs obliquely across the sternocleidomastoid muscle. The next step is to look for the highest point of the jugular venous pulsation in the neck. You may need to use a light source to help with the visibility. The next step is to measure the jugular venous pressure. Use a ruler or other measurement tool to determine the vertical distance between the highest point of the pulsation and the sternal angle, called the angle of Lewis, which is located at the junction of the sternum and the second rib. Normal jugular venous pressure is typically less than 3 centimeters above the sternal angle when the patient is at 45 degrees. A jugular venous pressure above 3 centimeters above the sternal angle may show a right heart failure or fluid overload or other cardiovascular events due to the increase in the central venous pressure. In our example, the jugular venous pressure of the patient is 2 centimeters above the sternal angle, which shows a normal finding. Thank you.
We see something in common in these different presentations, the high JVP. So let's first know how to measure it, then we go after some etiologies and important points. Hello again. Now for a final recap of important etiologies that can be reflected by the JVP measurement. So we have two branches of etiologies, the cardiac etiologies and the non-cardiac etiologies. Now some examples of cardiac etiologies. The right-sided heart failure, which is the inability of right ventricles to pump effectively, causing blood to back up into the jugular veins. Constrictive pericarditis, which is thickening of the pericardium restricting heart expansion, leading to elevated venous pressure. Next, we have tricuspid valve disease, like tricuspid regurgitation or stenosis, that can prevent proper blood flow through the heart, raising venous pressure. Finally, the pulmonary hypertension, which is increased pressure in the pulmonary arteries, leading to right heart strain and elevated JVP. While raised JVP is most commonly associated with cardiac etiologies, it is important to consider non-cardiac causes, like chronic kidney disease, which is impaired renal function, leading to fluid retention, causing elevated JVP. Liver cirrhosis, portal hypertension due to liver disease can cause fluid backup and elevated JVP. Superior vena cava obstruction, blockage or compression of the superior vena cava can impair venous return and increase JVP. And for the hypothyroidism, increased metabolic demands can result in elevated JVP due to high cardiac output and systemic vasodilation. We can also include pulmonary embolism. While PE is often considered a pulmonary issue, it can cause elevated JVP in some cases due to right ventricular strain from increased pulmonary vascular resistance. However, it's not always a direct cardiac etiology. Moreover, tracheal or mediastinal compressions, mass effect from mediastinal tumors such as lung cancer or other lesions can compress the venous return pathways, including the superior vena cava, leading to raised JVP. Finally, conditions that cause volume overload, like fluid retention due to excessive intravenous fluid, can result in elevated JVP due to increased blood volume and strain on the heart.
Hello guys, I'm Ahmed Twaini and now we're gonna solve these cases. In the first case, we have a 62 years old man with a history of hypertension, shortness of breath, distended neck veins, elevated proBNP, and high GVP. Is likely suffering from heart failure. The elevated proBNP indicates cardiac stress or failure, while the elevated GVP and distended neck veins suggest fluid overload, commonly seen in right side heart failure. Hypertension could have contributed to the development of heart failure over time. Diagnosis should be confirmed with echocardiography to assess cardiac function, identify the underlying cause. What about the second case? This is a 45 years old woman, a healthcare worker with a chronic shortness of breath, cyanosis, elevated D-dimer, and high GVP. Is likely experiencing chronic pulmonary embolism. The chronic shortness of breath cyanosis suggests ongoing respiratory compromise. Elevated D-dimer indicates clot burden or breakdown. High GVP points to right heart strain, often seen in chronic pulmonary embolism, where repeated emboli cause pulmonary hypertension and right heart failure. Confirmatory imaging like CT pulmonary angiography will be needed to that diagnosis. Finally, we have this 55-year-old male is presenting with classic signs of cardiac tamponade. The combination of hypertension, distended neck veins, muffled heart sound, pulsus paradoxus, and abnormal GVP suggests significant fluid accumulation in the pericardial sac, impairing the heart ability to pump effectively. Diagnosis is typically confirmed with echocardiography, which should show pericardial effusion. This requires urgent intervention, often pericardiocentesis, to relieve the pressure on the heart. So guys, now we are heading to the end of the video. With this MCQ, please leave the answer in the comment section and don't forget to subscribe if you want to be part of our community. Thank you for watching and see ya.